to yet another episode of the Core Consult RX podcast. Cole, how's your week going so far, man?
It's going okay. A little under the weather, but so I apologize if there's any sniffling or coughing in advance. But yeah, otherwise, actually, you know what? Today was a bad day. Anna was cleaning and found some water kind of underneath our refrigerator, and there was a leak in our fridge. And turns out I pulled the fridge out, and there's a whole bunch of water damage in the wall behind it, mold and stuff. So yeah, it's been quite a day.
Oh, jeez.
I know.
Was it has it been there for a while, you think? Or is it just something that your refrigerator started leaking just now?
It's like the water line that went to the water filter was just spraying this. It must have broke, and just this little fine mist of water out. So it could have been going for months, and the whole wall behind it is just like mold and bloated and
Jeez.
yeah. So that was what my evening was spent doing, was trying to figure out how to get the water turned off just to the fridge and not to the whole house, because I don't know anything about plumbing. So I did get it done like right before we got on a few minutes ago. So that was successful.
Jeez, man.
Yeah.
So you actually got it fixed though?
No, I got the water to our house turned back on. So I guess that part is
man,
fixed.
that's something.
Yeah,
that's progress.
It's progress.
But that's things, man. That's rough.
That's the way it goes. Home ownership.
Yeah, it's true. Well, I guess that could be a potential for actually a legitimate segue this time, because mold does put you at risk for what we're going to potentially be talking about tonight. But asthma is something we've covered a couple times, at least probably in the podcast. I think we've done one that was accredited back a while ago, but that one I believe is expired on Free CE's website now. So since the GNED 2024 guidelines have been updated yet again this year, we will be doing an accredited episode thanks to our friends at freece.com, and bringing you another recap of the asthma guidelines summary, if you will. So for those of you who are freece.com members already and have your unlimited membership, all of our podcast episodes that are accredited are included in that. And so for this episode, we will give you a password at some point during the episode. Use that to go on freece.com's website and look for this episode that matches the title of this podcast, or at least similar, and it'll ask you for that password. Use that to access the post-activity assessment and get your 1 hour of continuing education credit for pharmacists and nurses. And as always, thanks to freece.com for continuing to work with us. It's been 3 years now since we started working with them.
It's been a while.
It's been a while, so we're very thankful that they keep having us back. Either that, or they've forgotten about us, and they don't even realize we're still doing this for them. And
that's very possible.
They're sending automatic checks, and they don't realize it.
Yep, that's possible.
Yeah, I don't know if I think that was funny, or if I would just feel like really bad about that. I was like, oh, I thought they liked us this whole time.
Right.
But asthma is our topic tonight. What do you want? Any place in particular? Do you want to start, Cole?
Yeah. So you mentioned the GINA guidelines. That's an acronym for the Global Initiative for Asthma, which is a group that kind of puts out a lot of good info for asthma and has a number of kind of algorithms that we'll walk through. But just starting with the basics is what is asthma, or what do they say asthma is? It's defined by a history of a number of symptoms, respiratory symptoms like wheezing, shortness of breath, chest tightness, cough. It varies over time. It's not really consistent, and it varies in intensity as well. Together, along with variable expiratory airflow limitation, which we'll talk about, is how you can classify someone as having asthma. It's a heterogeneous disease. It's usually characterized by chronic airway inflammation, and studies definitely support the idea that there's a genetic predisposition to it, and there's certainly an environmental component as well to the development of asthma.
Yeah, and correct me if I'm wrong, but the COPD guidelines, the GOLD guidelines and the GINA guidelines, they're some of the only big groups of guideline publications, if you will, that kind of keep up their guidelines every year by year and updates, and post the newest guidelines at the beginning of each year. I mean, I guess the ADA does that too, but I really wish a lot of the other big, organizations would get on board with that, because I feel like that's very helpful instead of waiting like 8 years in between guideline publications.
Yeah, they are very consistent. They're very consistent.
It's very nice.
Yeah.
They must have some good funding or something. But like Cole mentioned, the pathophysiology behind asthma does have a lot to do with inflammation. Infiltration of inflammatory cells, especially when it comes to like eosinophils. We also will see mucus gland hyperplasia that can lead to mucus plugs, goblet cell hyperplasia. There's a lot of times thickening of the basement membrane. There's increased smooth muscle mass in the bronchioles, and it's because we have so many different, pathways and pathophysiology, biomarkers and whatnot. There's a lot of different targets for therapies now. We've come a long way when it comes to the treatment options, especially when there's what's referred to as like type 2 inflammation going on. There is several different unique targets that we're going after now, specific interleukins, and various others that we'll get into further on. But I think it's when I first learned about asthma, like in school, 12 years ago, I feel like I was just always thinking, just the inhalers, and you just kind of work your way up the steps of the algorithm, and you get to the end. But now there's a lot more to do with like the phenotypic profile and that type 2 inflammation that I think we'll definitely get into a little bit today.
Right.
So lots to do with lots of different targets for therapies, and a lot of stuff still in the pipeline.
In terms of your risk for developing asthma, or even some things that they've identified that can be protective against developing asthma, or at least putting you in a group that makes you less likely to develop it, there's certain environmental things. There's also certain genetic pieces. Interestingly, if you're the younger sibling like me, you're less likely to develop asthma. Mike being the oldest, I guess you were more likely to develop asthma. Natural birth and breastfeeding are protective factors against it. Also, farm living, agriculture, pig and cattle farming, consuming unpasteurized milk has been shown to be protective. Certain microbiological exposures, like having a diverse and healthy microbiota, but also things that may be negative, like foodborne pathogens like H. pylori, or other type of infections. Higher socioeconomic status has been associated with decreased rates of asthma or lower rates of asthma, and a healthy diet, low pollution rates, exercise, those things that you would anticipate are protective. Risk factors would be a family history, being born through C-section or formula feeding puts you at slightly higher risk. If you live around sheep, so if you're on a farm but live around sheep, or pressed or loose hay, that puts you at increased risk. If you live in an urban area and you have kind of altered dietary practices or community-associated infections, that can put you at increased risk. If your microbiota is dysbiotic, then that can be negative. If you have a history of having had respiratory viral infections like RSV, or bacterial pathogens like strep pneumoniae, that can put you at increased risk. Lower socioeconomic status, there's increased smoking rates, more stress, and other environmental factors like smoking, obesity, antibiotic use. These can all increase your risk.
Whew, that's a lot. And it's the farm living is very confusing. Is like you can have pig and cattle, but you can't have sheep, or you can have higher risk. That's interesting.
It's just the wool and the hay apparently is no good.
I guess that's more likely to cause allergic response or inflammatory response. It's interesting.
I guess so.
When you have a patient that you're first working up for a diagnosis of asthma, you're trying to pinpoint if that's actually what's causing some of their symptoms. Obviously, getting a history of the respiratory symptoms is important, but there are certain things that would make you kind of lean towards asthma even before undergoing spirometry. So let's say the patient is kind of experiencing wheeze, shortness of breath, chest tightness, and cough. And obviously those can vary between age and whatnot as far as how those descriptors are being relayed to the clinician. But as far as features that support the diagnosis, generally more than one type of respiratory symptom. In adults, like an isolated cough that's chronic is seldom due to asthma. So typically there's more than one of those types of respiratory symptoms present. Symptoms occur variably over time and vary in intensity. Oftentimes symptoms are worse at night or upon awakening. Symptoms can be triggered by things like exercise, allergens, cold air, even laughter in some cases. And symptoms often appear or worsen with viral infections. So again, that's not conclusive that is definitely asthma, but those things would support the likelihood of it being an asthma diagnosis versus some other type of respiratory condition.
Right. And there's certain symptoms that would decrease the probability that the respiratory symptoms are associated with asthma. Like if there's an isolated cough with no other respiratory symptoms, chronic production of sputum, shortness of breath that's associated with dizziness, lightheadedness, or peripheral tingling, chest pain, and exercise-induced dyspnea with noisy inspiration. These are less likely to be related to asthma.
Yeah. And when it comes to the true diagnosis, though, ideally we would want to get spirometry done and actually have pulmonary function tests at our disposal in order to hopefully look and get a bronchodilator response for these patients. But some of the things that you'll look at as far as spirometry goes when you get the report back, there's things like FVC. So that stands for forced vital capacity. So that's the maximum volume of air exhaled after taking a deep breath in. FEV1 is referring to the amount of air that can be forcibly exhaled in 1 second. And these are typically measured at baseline and then also measured again post-administration of a short-acting bronchodilator, basically testing for reversibility. And then also you're looking at FEV1 and FVC ratio, the percentage of the total air capacity that can be forcefully exhaled in 1 second is what that equates to, and there's a lot more they can go into the spirometry report. If you've ever seen someone's PFTs, there's a lot of other things they look at, but some of those are the main ways to kind of walk through, especially for someone who's not a pulmonologist, and when we think about like that FEV1, FVC ratios, is it low from the start? So when we say low, like usually less than 70%, that would indicate more of an obstructive defect. Whereas if it wasn't, that may indicate that it's potentially anyway more of a restrictive or normal spirometry, obviously. And then if the FEV1, FVC is low, less than 70%, looking at the FVC by itself, is it less than 80%? And if it's not, that could be more indicative of like pure obstruction, versus if it is lower than that, that possibly could be like this hyperinflation situation combined with either obstruction or restriction. And so that's where you would probably get a full spirometry workup if you haven't done that already to get some of these other more obscure values that a pulmonologist would look at. But again, if it's not FVC low is not low, it's less than 8%, then looking at the FEV1 and then also the reversibility with a short-acting beta agonist. So 12% increase in FEV1 from where it was prior to the beta agonist being given. If you do see that reversal, that greater than 12%, that is usually more indicative of asthma. If you're not seeing a reversal, and especially if they have other symptoms and things, that may be more on the lines of like COPD. But usually that beta agonist reversal is kind of indicating that the patient does likely have asthma.
Right. And that kind of goes to the second piece of the diagnosis, which is confirming the variable expiratory airflow limitation. So you pretty much touched on all that, but they would want to see a documented expiratory airflow limitation when the FEV1 is reduced, confirm that the FEV1 FVC ratio is reduced, and then also documenting excessive variability in lung function. So you mentioned having that improvement in lung function after using a bronchodilator. There's some other tests they can perform to confirm that there is substantial variability, but that's another item they need to have for the diagnosis. Currently, asthma severity is assessed retrospectively from the level of treatment required to control their symptoms and then how many exacerbations they're having. Severity can be assessed once the patient has been on control or treatment for several months. If it's appropriate, attempt to step down the treatment to find the patient's minimum effective level of treatment. And they kind of stratify the severity, as you might imagine, mild, moderate, and severe. Mild asthma, currently controlled with an as-needed ICS formoterol. Moderate asthma is asthma that's well controlled with step 3 and step 4 treatment options, which we'll talk about. And severe asthma is asthma that's uncontrolled despite having high dose ICS LABA therapy. And we'll touch on each of those in a bit.
Yeah, and one thing, just because I don't know the perfect place to kind of put this in here, but one thing that was new with the 2024 GINA guideline update was when they were talking about initial asthma treatment. And we'll get to the actual stepwise approach and the preferred track versus the alternative approach or track 2 when you're initiating treatment. But previously, the guidelines stated that if patients are experiencing symptoms less than 2 times per month without exacerbation risk factors, then they were considered suitable for step 1 treatment. Now, the criteria has shifted a little bit to where step 1 treatment in track 2 specifically, which is referred to, as like infrequent asthma symptoms, is defined now as 1 to 2 days per week or less. And so more patients would probably qualify for a true step 1. And I think some of the reasoning behind that, and possibly the main reasoning behind it, is that they've changed that recommendation because they were trying to limit the use of patients who were on SABA only treatment. So SABA only treatment is no longer recommended. In fact, obviously when we get to the treatment guides, we'll see how important it is to have an ICS on board with that bronchodilator and how that can help with inflammation over time and reduce some of the risk of exacerbations and whatnot. And so that verbiage has changed a little bit, and so step 1 patients can have that as needed therapy, but it's going to include some kind of an ICS, and we'll obviously get more into that, but just that quick change in verbiage. And I think the symptomatic criteria for step 2, again on the alternative approach, used to be symptoms 2 times or more per month, but less than 4 to 5 days per week. Now they've changed it to less than 3 to 5 days per week with normal, mildly reduced lung function. So just some mild changes. And again, I think it's more semantics to help cut down on confusion and to get clinicians to move towards that idea of, even if we're using as needed therapy, combining that SAMA or as we'll talk LAMA and a ICS is going to be important.
Right. Just finishing up on some tools that you can use to differentiate between the levels of symptom control. There's some numerical asthma control tools like the Asthma Control Questionnaire, the ACQ, and has scores ranging from 0 to 6 with some questions associated, higher being worse. There's also the Asthma Control Test, the ACT, not to be confused with the standardized test I did poorly on a long time ago. Scores ranging from 5 to 25, with higher being better in this case.
Yeah, and when we actually talk about treatment, there's always been this sort of stepwise approach. In fact, the algorithm is illustrated as actual steps, and we've had track 1 and track 2 in the past, but they've definitely shifted quite a bit. I want to say this started occurring in 2019-ish, but we'll talk about some of the alternative tracks. But one of the big changes is the use of ICS and formoterol combination, even early on, as early as steps 1 and 2, and kind of using that inhaler as both the rescue inhaler and the maintenance inhaler. If the patient needs scheduled doses as well. We'll get into the actual medications and we'll come back to the algorithm in a little bit. But we do want to kind of go through some of the background on some of these medications and inhaler devices and whatnot. And in fact, the inhaler device itself can be a really important part of selecting therapy. There's definitely patients out there who, for whatever reason or based on certain comorbidities, even, it could be something as unrelated to asthma as, hand osteoarthritis. They can make a huge difference on which inhaler you pick as far as how the patient responds and is able to get the benefit from that treatment. But, the inhaler device, very, very important to make sure that when you do have, a patient started on or getting started on a medication, especially one they've never used before, and with all the different inhaler devices out there, that you provide them some type of skills training, whether that's showing them in clinic or giving them a handout or whatnot. But some statistics show that a lot of patients have difficulty with. In fact, there's some that say up to 80% cannot use their inhaler correctly. And I think I've told this story before in the podcast, but I've definitely seen this firsthand where a patient was telling me their Spiriva HandiHaler was not working very well and they wanted something else. I had them bring it into the clinic and show me how they were doing it. They popped the foil cap open, tossed the capsule in their mouth, swallowed it, and then just breathed air through the device itself. And
Classic.
I was like, ooh,
Classic.
I think we figured out the way that the problem that may be causing this ineffectiveness. But obviously the inhaler device not being used correctly is very, could potentially contribute to poor symptom control as well as exacerbations. So making sure you're choosing the right inhaler on top of obviously what the insurance will cover and everything. And then once the patient's been started on, whatever inhaler they were put on initially, when they come back in for a follow-up, it would be a good idea to tell them to bring their inhaler with them and kind of demonstrate or at least walk through how they use this at home and see, make sure their technique is proper and they're not doing anything wrong. And then, making sure that you're kind of familiar with the inhalers yourself. So getting samples or demo devices and whatnot if you're in clinic and making sure that you're able to explain this. Worst case, there's definitely diagrams and videos and stuff online, but getting to see how the patient does it at follow-up, I think is something that oftentimes gets overlooked or, not requested of the patient to bring their inhaler in.
I wonder if people are still using that old HandiHaler instead of the Respimat these days. Though I feel
like I've definitely seen a few of them, within the not too distant past, but I definitely see the Respimat used more often. But I have seen some people on the HandiHaler still, and I always assume it's an insurance thing, but
yeah,
it seems like a much more flawed design.
I seem to always have a lot of people have trouble with the Respimat too. The cartridges and whatnot. I don't know what it is.
Well, when I mentioned the hand osteoarthritis, that's where I've run into that before. Is patients literally couldn't. I've had a couple of times where patients literally just could not get the base to twist. That in order to prep the dose to be inhaled, they couldn't twist the bottom of the inhaler all the way to where it would lock.
Yep.
And so that was really problematic for patients, and they didn't want to say anything about it. They were just skipping doses, and it's like, oh, let's get you a better fit for you. I think that's something that's very easily overlooked because I know I'd never even thought about that until, which is probably very ignorant on my part, but had never thought about that until I actually ran into it in practice.
Yep. Doesn't matter what you prescribe if they can't use it.
That's a good one. Yeah, it's very true.
So we'll go through a few of these inhaler types and some things to note with them. The metered dose inhaler being a classic with aerosolized liquid medication inside. Some use a propellant, which is the HFA, if you've seen that on the box. But it requires a slow, deep inhalation at the same time as pressing the canister, so a little bit of coordination there. A spacer can be used for patients who can't coordinate, so children or just individuals who can't. Then there's dry powder inhalers. The dose is a fine powdered medication. There's no propellant. The administration requires a quick, forceful inhalation, and you can't use spacers with this one. You also don't need to shake those. Nebulizers turn the liquid into a fine mist where the patient can breathe naturally through the mouthpiece and get the medication. So those are three common types of inhalers.
Yeah, and some of the other, obviously the brand names like Respaclick and Ellipta and all those, again, still they may be easier to use and whatnot, but they still may not be a great fit, or they may have certain things where you waste the dose if you open the cap and then put it back. So always making sure that you're familiar with these, and they're definitely not created equal. Did we ever mention how the Respimat inhaler itself, like that design came about? I heard this from a clinical science liaison that worked for the company that makes Breve. So I'm assuming this is true because he said it very confidently. But basically said that the engineer that came up with the Respimat design was sitting in traffic one day and watching the exhaust from the tailpipe of a car in front of him coming out, and just kind of had the idea of man, that would be really cool if that was a way to, because I guess he either had asthma or had somebody in the family that did or something. But it was that'd be a really cool design for a inhaler, and I guess came up with the idea, or had a team that came up with the idea. But supposedly it started from sitting in traffic and just kind of noticing that as he's going on the way to work. I thought that was pretty interesting.
Yeah, it sounds like a good way to sell you some medication, is to tell that story.
Listen, okay, now you're gonna make me do research now just because I'm gonna feel stupid if I told that story. He was very convincing if that was a lie.
I'm sure he was.
Okay, you know what? I also signed up for a pyramid scheme. It's not a big deal. All right, so let's get into some of these medications. One of our oldest medications that we're all familiar with, albuterol, comes in a lot of different forms. It has a lot of different, brand names, if you will. So ProAir, Ventolin, Proventil. It's essentially a short-acting beta-2 agonist. It also has a similar medication, levobuterol, Xopenex. That one you don't see as often, and some people say they can notice a difference as far as some of the side effects go, and less of the nervousness and tachycardia and all that with the levobuterol. But I see mostly if albuterol is being used, it's usually, or a SABA is being used, it's usually albuterol. These will have their effect very quickly, and they open the airway within minutes once the dose is inhaled, and so they're oftentimes referred to as rescue inhalers. The peak time as far as their action is 30 to 60 minutes, with usually a duration of action of around 4 to 6 hours. And adverse effect wise, I just mentioned a few: the nervousness, the tremor, tachycardia, palpitations. They can even cause cough and hyperglycemia. Those things, when you're using a SABA appropriately, aren't usually too big of an issue. Although if somebody does have underlying comorbid anxiety and or tachycardia or something like that at baseline, this can definitely worsen even with limited use. But the problem with these side effects is when you have patients who are using their albuterol much more frequently than they're supposed to, and not being put on some kind of a maintenance inhaler. That's when those side effects can really become problematic. And I've definitely seen patients where their anxiety gets, extremely exacerbated because they're using their SABA 6, 7, 8 times a day.
Right.
And it's let's get you on a better regimen, and hopefully your other comorbidities will improve as well. But if you're using the rescue inhaler more than 2 days per week, that's probably indicating that it's worsening of the asthma control, and you may need to consider a better maintenance inhaler.
Right. So another short-acting option that we have are the short-acting muscarinic antagonists. We'll call them SAMAs. Ipratropium is an example, typically used in COPD, but they're sometimes used off-label in asthma exacerbations. They have a quick onset within minutes, but they're less effective than the SABAs. They have a peak at 2 hours. They'll last about 4 to 6 hours, but they have some adverse effects like dry mouth, scratchy throat, a bitter taste would be some of those.
Hey guys, I'm sorry to interrupt the episode, but I wanted to tell you briefly about our sponsor, Freed AI. Do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you are shaking your head yes, keep listening. Freed is an AI scribe that makes charting go away. It does your notes for you. Freed listens, prepares your notes, and writes patient instructions. Charting is done before your patient walks out of the room. Freed learns your style over time, just like a human scribe would. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. You can try 10 notes for free, and after that, it only costs $99 per month. You can find out more information at their website, www.getfreed.ai. Check them out today. Back to the show. And one of the main focuses of treatment when it comes to asthma is our inhaled corticosteroids, our ICS. So these, there's several different options available now, both as combination products as well as standalone ICS agents. But just to name a few, budesonide under the brand name like Pulmicort, they have a nebulized formulation. They have a flexhaler form. Fluticasone, propionate is like under the brand name Flovent. There's also a newer version, fluticasone furoate, which because of its estrogen binding or hydrogen binding rather with that ester with the furoate, you get better, I guess, hydrogen bonding, and that allows you for once a day dosing versus traditional twice a day dosing with fluticasone. But either option is going to be fine if you want to go that route. It's just a matter of how often the patient wants to dose. Mometasone is another one that's out there. Beclomethasone, QVAR. I've seen some patients being put on that one, but really any of these are going to be appropriate. And for me personally, it usually comes down to obviously insurance coverage and the inhaler device that particular ICS comes in. I like the Arnuity Ellipta a lot. One I'm not a huge fan of. I don't know if you've ever seen the Asthma-X Twisthailer, the mometasone.
I have seen
not a big fan of that device. So that would be one that I personally would probably want to steer away from. But again, going back to the devices, that's obviously something to keep in mind and not just looking at the name of the ICS. Adverse effect wise, a big one to consider and educate patients about is the risk of thrush. If a patient uses the ICS and then lets that steroid stay on the tongue, that steroid can kill off some of the bacteria that naturally occur in the mouth, and a fungal infection could start to grow kind of uninhibited, and so patients can develop thrush if they're not rinsing their mouth out properly. Also, it can start to cause a cough. A lot of these are kind of irritating to the throat, and so that chronic cough can start to occur, and obviously could cause some concern and make the patient start looking as far as other diagnosis and whatnot. So the moral of the story is making sure the patient is rinsing their mouth out after use of any product that has an ICS in it, and reporting any changes, in that regard. But the other thing that's really important to kind of double check with inhalers or with ICS inhalers in particular, whether they be standalone or combination products, is one, whether they have twice a day or once a day dosing, because there's several different options and a lot of them have either or dosing, and so you got to make sure which directions go with which device or which product. And then the other thing is which ones would be considered to be like a high potency, medium potency. There's some products out there that don't necessarily have like the high dose option available. And so, like, to give you an example, and I'm going to pull this chart up. Pearls has, the sponsor, one of the sponsors of this podcast that you've heard us talk about for quite a while, has a great chart on their app that kind of goes through low dose, medium dose, high dose, and which of those are available. And so it talks about, it shows you basically a breakdown of how many doses per day and how you would need to get to the dose that would be considered medium or high dose. So as you're working your way up that stepwise algorithm for treatment, you have a good breakdown of kind of how to get there. But one thing I thought was interesting is like Symbicort, Bristol, they kind of don't really have what would be considered like a high dose option, whereas a lot of the others do. But Symbicort, you'll see, is one that we do actually use quite a bit, and it can be effective. But I just thought that was kind of interesting in looking at this chart. But if you ever need a reference, this one's fantastic, and it's aesthetically pleasing too. I like the way they did this. So check that out.
They're much better with design than I could ever be.
Oh my gosh, it's not even close.
Color
schemes. And I'm talking about me too. Yeah,
I don't understand color schemes. I don't know why colors go with other colors.
I thought they were made up until I saw Pearl's algorithms, and I was like, oh man, they're they're better at this than I am.
They open your eyes. Before we do the long-acting beta agonist, do you want to do the password?
Yes. Password for today's episode is going to be FEV24. So FEV, all capitals, and then the number is 24.
Not a great FEV.
Make sure you get your continuing education credit and count this towards your new license renewal.
Do it.
Long-acting beta-2 agonist, LABAs.
Yes. So we'll talk about those next. For example, salmeterol, which is the Ceravent Discus, is administered twice daily as a maintenance therapy. They do have a box warning for increased asthma-related deaths. This is related to a study called the SMART trial. Had over 26,000 patients with salmeterol versus placebo, and they saw 13 deaths from asthma in the treatment group versus 3 deaths in the placebo group. So never use LABAs as a reliever. They should not be given without an inhaled corticosteroid.
Yeah, and that's the key, is it's the LABAs that are by themselves. And really, we don't see too many of those anyway nowadays, but that if it's like something like Cole mentioned, salmeterol just by itself, so Ceravent Discus, that cannot be given to someone with asthma without the ICS being added onto it. However, that's completely not true in COPD.
Yeah.
So I think that gets really confusing for people, but there are situations where you may see someone on Ceravent by itself in a COPD patient, but not in asthma. And in fact, they did some follow-up studies because if you remember, they used to have every product that contained a LABA, whether standalone or combination, used to have this box warning as far as that risk of asthma-related death. But then they did a study called Vestry that looked at salmeterol fluticasone versus fluticasone. And then they did another study that was somewhat similar to that, but they just did it in a little bit older patients. The Vestry was done in 4 to 11-year-olds. But they were looking at, kind of how patients responded to treatment as well as, possible negative outcomes. And they saw that, the patients didn't have that same risk necessarily with when you had the ICS added onto it. And so because of these studies that came out, if a product is in ICS and in LABA combo, the FDA allowed them to remove the box warning on that combination because of some of these safety studies that have come out showing that it's truly just the LABA without the ICS that's causing the problem. And I will say that there's some data to kind of explain why that is. The long-term beta agonist activity does seem to lead to this downregulation of beta receptors. And so the thought was that the longer you're using this LABA, especially if the patient starts using it more frequently than they're supposed to, then you can get such a downregulation of the beta receptors that it's no longer responding to the LABA, which could increase their use of it if they don't consult their clinician. And then also if they had an exacerbation and were brought to the hospital, there were cases where they were giving nebulized albuterol and it wasn't working. And so one of the things that has been suggested is that corticosteroids can possibly upregulate those beta receptors again to kind of regain that ability for the beta agonist to interact with it. And then also on the contrary, studies have shown, or not the contrary, but I guess on the other side of that is that studies have suggested that LABAs actually can activate corticosteroid receptors, which possibly enhances the transcription of anti-inflammatory mediators and the response to an ICS. So there seems to be this synergistic activity between an ICS and a LABA that also kind of is beneficial for someone with asthma. So long story short, the moral is do not give LABA by itself unless you're giving ICF. With asthma patients, not in COPD, not a big deal.
Right. Don't do it in asthma patients.
Yes.
There are a few ICS LABA combinations like Symbicort, budesonide, formoterol. There's the Advair Discus with chest, salmeterol, and fluticasone, Dulera, mometasone, and formoterol, and then the Brio Ellipta, which is fluticasone and vilanterol. Be aware of what the insurance's formulary prefers for your patient and whether it's twice a day dosing or once a day dosing, depending on which product it is. And also be aware of the device that the medication is going to be administered with. And like Mike mentioned before, so we can provide appropriate counseling.
In the next class of meds we'll talk about, this is one I'm not a huge fan of, but like leukotriene modifying agents. The one we'll touch on in particular, montelukast, is one that I'm sure everyone's familiar with, brand name Singular. These, as far as their effectiveness is kind of debatable, I'd say, and a lot of patients don't really get too much benefit from these. They can help in certain situations, maybe where the patient's having to deal with like allergic rhinitis as well as asthma. They could be a possible agent to sort of help both situations at once, but I haven't personally had a lot of luck with using these with patients. And I know they are still out there, but not something that you see as often anymore. They're definitely not emphasized as much in the guidelines. Some side effects that can happen with montelukast, it's fairly rare, but definitely in some situations can cause like abnormal dreams or anxiety. And so if a patient has like pre-existing anxiety disorders, maybe, use caution there. And also in 2020, montelukast in particular got a box warning put on by the FDA because of noted behavioral and mood changes. And I did look into that a little bit when that first happened, because a lot of people were kind of freaking out, especially patients that started reading this in the news and stuff. And really their main focus of putting that in there and making it a box warning was because the knowledge of that montelukast causing some of these behavioral and mood changes in general, and like worsening anxiety disorders and whatnot, was so unrealized by clinicians that they just needed to bring attention to it. So they kind of converted it into a box warning. So they kind of made a point of saying, if you've been stable on this medication and haven't noticed, changes or anything, then obviously you shouldn't have to worry about that. But they just needed to bring awareness to it because it was so few clinicians that I guess were even aware that was a possibility, and were just kind of like anybody who needed it could get access to it. So
right.
Just to put an extra safety, net there. But other adverse effects that are more common, things, obviously headache, dizziness, some abdominal pain has been reported, increased risk of upper respiratory tract infections. But one good thing is montelukast is approved to patients as young as 1 year old, studied down to 6 months. And so they do have formulations available, like in granules that can be dissolved in formula or mixed, with applesauce or something. So if you have a very young child suffering from asthma, then this could be a potential add-on therapy that has a formulation they can actually use.
Right. There's another drug called Zyflo or Xyloton. It's a 5-lipoxygenase inhibitor. It's dosed 4 times a day unless you use the CR version, which it is available in, dosed twice daily within 1 hour of food. It does have some drug interactions with warfarin and propranolol, and there have been some reported cases of hepatotoxicity. So you want to get baseline LFTs, then check them monthly for about 3 months, and also counsel to avoid alcohol with this drug because of the risk for liver toxicity.
Yeah. Have you seen that drug in a while? I feel like it's been over 10 years since I've seen anybody on that.
I haven't seen it at all. No.
Yeah. It's and the only reason that one sticks out in my head is because I used to work for a Walgreens that had it like with dust covered all over it in the back corner of their shelf. It had been there for a long time, and I would always just notice it.
Just wasn't returnable and didn't expire for a long time.
I guess so, but I don't know why that just popped in my head. But yeah. Another class that we're probably familiar with, but can definitely be useful in asthma, is the long-acting muscarinic antagonists, or LAMAs. The standalone agent that kind of got its this class of medications variety in treating asthma in particular was tiotropium. And in fact, when Spiriva Respimat came out, so they were trying to find an alternative to the HandiHaler, like we talked about earlier, there was 2 different doses that were available, one for asthma, one for COPD. And there was evidence showing that, tiotropium added to standard combination therapy did further improve, patients' asthma symptoms. Obviously, it's not like it would be in a COPD situation where LAMAs are kind of like the go-to option, even is monotherapy. In asthma, we still want to focus on the ICS-LABA first, and then kind of have the LAMA as a backup if we need additional, therapy options. But those are the kind of main, medication options as far as going through that initial stepwise treatment algorithm. And cool. Do you want to just kind of walk through like the preferred approach, and then I'll go through the alternative?
Yeah. So I'll kind of walk through the GINA guidelines preferred approach for individuals 12 years and older, which would be to start stages 1 and 2 would be a place to start if the patient's having symptoms less than 3 to 5 days per week. For any of these steps, the preferred reliever option is as needed low dose ICS formoterol. We'll touch on that in a bit. But for steps 1 and 2 as the controller medication, you can use low dose ICS formoterol. So it can serve the purpose of the controller and the reliever in this instance. If the patient's having symptoms most days or waking up with asthma at least 1 time per week, or they have low lung function, then you would move up to step 3. In this case, the controller would be low dose maintenance ICS formoterol. So you're using it consistently as opposed to as needed, but can be used as needed as the reliever.
As the rescue, yeah.
As the rescue.
As well. So you're basically taking additional doses of your maintenance inhaler.
Right, for your reliever. If the patient's having daily symptoms, they're waking with asthma at least once per week, and they have low lung function, or they've had a recent exacerbation, you'd move up to step 4. This is where you would get into a higher dose, basically a medium dose maintenance ICS formoterol, again with the as needed low dose ICS formoterol as the reliever. If in step 4, a short course of oral corticosteroids might be needed if initial asthma presentation, if they present during an exacerbation of asthma. So you might have to do a taper of steroids as you increase the dose of their controller.
And that's where all the llamas and we'll get into the biologic therapies in just a little bit, but that step 5 is where a lot of that stuff really comes into play.
Right. Yeah. Step 5, you might have to add on a llama, might have to do biologic therapy or a higher dose of the ICS formoterol. In all these cases, they suggest assessing the patient, confirming diagnosis, addressing proper inhaler technique if their symptoms aren't controlled, and then adjusting to treat their comorbidities and modifiable risk factors, again, reassessing their skills and proper use, and then reviewing their lung function, exacerbations, side effects, what's their satisfaction and quality of life, kind of in each iteration of the steps they suggest this.
And the track 2 or the alternative approach is one that includes albuterol as the reliever. However, even in step 1, so patients are having symptoms less than 1 to 2 days per week, you would still have the ability to use albuterol as the rescue inhaler. Again, this is the alternative approach, not preferred. But every time you take a dose of the albuterol, they'd want you to have a dose of an ICS as well. And then as you kind of increase in the steps 2 and 3, it's using the ICS as maintenance in therapy, and then the SABA, the albuterol, as your rescue inhaler, and you just increase from low dose to higher dose if possible, or adding once you hit step 3, you could do ICS LABA as your maintenance inhaler, and then take a dose of albuterol as the rescue. But that step 1, I think, is oftentimes something we don't think about. It is if you're using albuterol and you don't have a set maintenance inhaler, they still want you to add on a ICS that can be taken as needed along with the albuterol, kind of mimicking the idea of the preferred treatment, but just in a more inconvenient way, I would say.
Right. And we touched on this a few years ago. I guess it's been 3 years now since this was kind of big news, but historically, like Mike mentioned, the SABA was the preferred as needed reliever option. So why did they switch it to the ICS formoterol? There was one trial called the Sigma-1 trial, which included as needed terbutaline as one of the arms. That's a SABA that is not used much in the States. And comparing it with budesonide formoterol, it was superior to the terbutaline group. So that's part of where it came from. There's also a study called the START trial, double-blind, placebo-controlled, that showed budesonide formoterol used as needed resulted in a lower risk of severe exacerbations than the as needed use of albuterol. So kind of the combination of those two things, plus some maybe enhanced understanding of mechanisms booted albuterol out of the preferred reliever spot.
And I think everybody, formoterol is a LABA, and I think that initially is, when this first came out, I think it really confused a lot of people because we've always been, told not to use a LABA as needed. But the reason why they were so specific about budesonide or an ICS with formoterol specifically, that particular LABA, is because if you look at the onset of action of albuterol, which is like 5 to 6 minutes or so, formoterol's onset of action is like 6 to 7 minutes. It's very similar. Whereas like salmeterol or something like that, you're talking 30 minutes to, for onset of action. And so that it's a LABA in the sense that it has a longer duration of action. However, it's got a onset of action as if it's a SABA. So it's like this weird hybrid, I guess you'd say. And that's why the guidelines in the studies were so specific about, formoterol being the LABA that's combined with the ICS. And so if you have a patient who is being prescribed the, let's say budesonide formoterol Symbicort as their maintenance inhaler as well as their rescue inhaler, which would be the preferred option, once you're reaching like steps 3 or so, the patient would take their dose, of Symbicort twice a day, just like they would, for any other maintenance inhaler. But if they have symptoms and they need an additional dose, they can just use that same inhaler, the Symbicort, to get a reliever dose, if you will, and hopefully take care of their shortness of breath. And so the maximum recommended total dosage of formoterol in one day is 72 micrograms. And so kind of going through with patients that in using that same inhaler for both situations, I think cuts down on a lot of confusion possibly, where if they're having an episode of shortness of breath and they're looking for their inhalers, they may grab the wrong one. But definitely seems to be a very effective option and convenient for them to just have one inhaler, unless they start reaching like stage 5 when we start adding in some of this other stuff.
Right.
And I don't know if any of y'all have even seen this drug before, but there wasn't albuterol was not about to go down without a fight. And so albuterol and budesonide under the brand name Air Supra, change that name, please. Air Supra was approved in 2023. I hate that name so much. And really, it's kind of put out to be the same thing, where you can do, use this combination as a rescue inhaler. However, it's not approved, at least to my knowledge. This hasn't been changed. It's not approved for maintenance therapy.
Right.
So it still requires the patient to have 2 separate inhalers, and formoterol has a longer duration of action, making it a LABA in the first place. And so it kind of still doesn't address that, aspect of it. It does make it easier than having to have, an ICS by itself and a albuterol by itself and using a dose together. But I haven't seen anybody actually on this, but it's just seems weird that they came out with this one.
Right. As we come in for a landing here, we'll kind of touch on some of the biologic options in severe asthma, but also specific types of asthma. So there's one drug called Xolair, which is an anti-IgE. It's omalizumab. Patients can be eligible if they have, for this drug, for severe allergic asthma, if they've had a sensitization on skin prick testing or specific IgE, total serum IgE, and weight within the dosage range, and exacerbations in the last year. There's certain lab tests you can get and factors that may predict a better outcome with this drug, but indicated for moderate to severe persistent allergic asthma. It's approved 6 years and older. It's a monoclonal antibody, like most of these biologics, that inhibits IgE binding to the IgE receptor on mast cells and basophils. It's a sub-Q injection given every 2 to 4 weeks, depending the dose and the frequencies based on their pre-treatment IgE serum levels and then their weight. They should have IgE levels between 30 and 700 international units and shouldn't weigh more than 150 kilograms. It does have a box warning for anaphylaxis, which there's always a risk for anaphylaxis with these injections, but kind of unique to have a box warning for it. So it's supposed to be given in a healthcare setting under medical supervision, because of that, the anaphylaxis has occurred as quickly as after the first dose. It's also occurred after a year of starting treatment, so kind of at any time. Associated with a slight increased risk for cardiovascular events, but more common side effects would be injection site reactions, maybe some pain, dizziness, fatigue, that sort of thing.
And we also have our interleukin-5 receptor antagonists. There's 3 of them. And if the patient has severe eosinophilic asthma, and this is where like that type 2 inflammation profile comes into play, as far as step 5 goes, the positive skin prick test, like Cole mentioned for the Xolair, with the elevated IgE count, this would be, patients would be eligible for one of these anti-interleukin-5s if they've had an exacerbation in the last year, and if their blood eosinophil count is equal to or greater than 150, or some guidelines will say greater than or equal to 300, but you would probably get with higher blood eosinophil count, you would get a more likely, positive response, but technically 150 or higher is the cutoff. For blood eosinophils. So they have Nucala, they have Sincara, they have Fasenra is the 3 that are out there available. They all have slightly different dosing and can be given sub-Q. And just for time's sake, we won't go into the differences between each of those, but all 3 of those would be options if a patient, is fitting that type 2 inflammation profile and meets that criteria based on their eosinophil count. Interleukin-4 inhibitors are also available, and specifically there's the medication that we've talked about with like atopic dermatitis and whatnot, Dupixent. And this one still requires the patient to have an exacerbation from the previous year, and that blood eosinophil count of 150 or more up to 1500 or more. Again, higher eosinophil count equals higher likelihood of success. There's also, if the patient has a forced nitric oxide of 25 or more parts per billion, that would also be an indication. The one that I always keep in mind for for Dupixent in particular is if a patient is taking maintenance oral corticosteroids, on a daily basis. That, in fact, I've done a prior authorization for one of these myself, and that was one of the first things they ask is, obviously what treatment have they already tried, and then are they taking daily steroids? Person was, and they approved it immediately because it's been shown to help get off of oral steroids. Yeah. And so it's still a sub-Q injection, and that's one that I tend to think of in that particular case. And if it's more on the eosinophil count, then I'm thinking the interleukin-5 inhibitors instead.
Right. There's also an anti-TSLP, which is thymic stromal lymphopoietin, called tezepelumab. Has a EKKO at the end, kind of like a biosimilar. But it's another sub-Q injection every 4 weeks, and it binds to TSLP and prevents its interaction with its receptor complex. It does have some mild side effects associated with it, and a minimum baseline level of blood eosinophils is not required, or the ferrous nitric oxide.
Yeah, and that I think is a great option, because when you get into this like step 5 approach, where you're looking at, besides a LAMA, if they do have possible, type 2 inflammation, and you want to use one of these more targeted treatments, if the patient didn't have certain criteria, they didn't have really anything available to them, which this offers now an option. So just to kind of recap this, and if you ever are looking at the guidelines, they have a whole page dedicated to the assess and treatment of severe asthma phenotypes. And this is after you've kind of reached step 5 and you're still having symptoms and or worsening, symptoms, then you're kind of looking for the possibility of one of those type 2 targeted treatments being appropriate. And so like Cole mentioned with the Xolair, that would indicate, a total IgE and weight, within the dosing range, as well as that sensitization to a skin prick test or a specific IgE, and also an exacerbation in the last year, that would qualify the patient to be a candidate for possibly that anti-IgE option of Xolair. And then if they've had an exacerbation, their blood eosinophil count is 150 or higher, then that would indicate a possibility of one of those interleukin 5 inhibitors. And then if they're taking oral corticosteroids on a daily basis, that would maybe lean more towards the Dupixent. And then if none of those things apply, but they have had an exacerbation in the last year and you're kind of limited on what else you can add on, that's when the Trespire, that anti-TSLP medication, comes in clutch, because that doesn't require a specific blood eosinophil count or like Cole said, a forced nitric oxide level. So it is noted that it tends to work better if a patient does also have higher eosinophils and whatnot associated with their asthma as well, but it's not requirement like the interleukin 5s would be.
Right.
And I guess since we're almost out of time, the one thing I do want to mention real briefly is the consideration of step-down treatment. And actually, there was a new addition to this section for the 2024 GINA guidelines anyway, because I think that sometimes patients will get put on therapy and, things are working for them. They're not having symptoms anymore, but then they just get left on therapy or that same therapy for long periods of time or indefinitely. And the guidelines do mention that if a patient is having good asthma control, good symptom control, and they have been able to maintain that control for at least 3 months or longer, it is okay to start to de-escalate or step down treatment and try to find what the lowest treatment that controls both symptoms and exacerbations is for that patient, and as well as minimizing the obvious side effects and whatnot. So making sure that obviously the patient is on board with that and willing to start that process of possibly stepping down therapy, but use a very stepwise approach, just like we would use a stepwise approach to increase, or intensify therapy. We want to make sure that, let's say we're, using an ICS LABA combo or even the ICS formoterol, in that, over the next 3 months, maybe bringing the dose down 25 to 50% of the ICS dose, waiting another 3 months to see how the patient does. If they're still having great control of their asthma, then maybe another 25% until, maybe you can get off of that or go to as needed if you're using the ICS formoterol instead of having it scheduled every day. And then the change with the guidelines, or the addition to the guidelines this year, was the idea of what to do if the patient is on targeted therapy for that type 2 inflammation. So I'm just going to kind of read this just so I'm not summarizing, but the previous step-down algorithm did not provide specific recommendations for patients who responded well to therapy that was targeting that type 2 inflammation. And so in the 2024 guidelines, they say that if a patient who is responding well to a regimen of a biologic therapy plus high-dose ICS LABA could be considered for discontinuation of the other add-on medications, specifically oral corticosteroids, followed by a reduction in the ICS LABA if they're not on oral steroids. And so they're basically saying that if the biologic is working well, that maybe limit the dosing of the other medications, the other maintenance meds, instead of just stopping the biologic. And that's still a debatable, thing as far as how long patients can they just be on these biologics indefinitely. Hopefully, as time goes on, we'll have continuing, or we'll continue to have more and more long-term safety data. But the guidelines do actually address it, at least briefly, in this particular guideline.
Yeah, they sure do.
Anything else? Yeah, good. I made it all up. Gotcha. Don't ever agree with me, Cole. Anything else you got for this section at all?
That's all I got, man.
So you're going to give us an update real quick before we go on your plug-in for your literature searching?
Yeah. MedSearch Chrome extension. People are still downloading it. Hope you're enjoying it, but just check it out on the Chrome Web Store. MedSearch, and might save you a few minutes a day.
Very nice. It's nice to know we have a software engineer on the team now. Very excited about that. Also, if you haven't checked out Pearls, pearls.com/coreconsultrx, make sure you go to, at least their free option that they have. They have a lot of great content, and they're updating it constantly. We used several of their charts and algorithms and whatnot for this episode, so definitely check them out. And like I said, the free version, you still get access to a lot of great stuff, and if you can cancel that at any time. Also, for those of you who want more like structured lecture style podcast, or not podcast, but content, check out patreon.com/coreconsultrx. We have new lectures going up there. I will admit I have been a little bit slow this month publishing stuff on there, so I apologize. There's a brand new lecture on CKD, and there'll be another one on a patient case with CKD later this week, but definitely check that out. And it's a fairly cheap way to kind of just do some simple reviews of your pharmacotherapy for different disease state managements. But other than that, thank you guys so much for listening. And if you have any questions for Cole or myself, definitely send us an email, reach out to us on social media, and we will see you all on the next episode. Have a good one.